Okay, so you've given us quite the stack of information here on chest pain.
Oh, yeah, quite a bit.
And,
Right.
right.
And our sources emphasize that getting a clear history and doing a thorough physical exam are like the cornerstones of this whole process.
Right, so it's all about getting the story straight.
Yeah, exactly. It's like the foundation.
And speaking of getting the story straight, there's this mnemonic that they talk about in the excerpts called OPQRST. Have you heard of this?
Oh, yeah, OPQRST. That's a classic. It's like a little roadmap for understanding pain.
Yeah, like puzzle pieces or something.
Exactly. So it stands for onset, provocation, or palliation, quality, radiation, severity, and timing.
Okay, so not just about the immediate pain itself, right? They
Yeah.
also talk a lot about how important your background health information is.
Oh, absolutely. Knowing your medical history is so important in this context.
Yeah.
Things like, do you have high blood pressure or diabetes, high cholesterol? Have you ever smoked? Do you have a family history of heart problems? All these things are really important clues.
Yeah, it's like painting the whole picture.
Exactly.
Yeah.
It helps us understand your overall risk profile.
And have you had any previous procedures like stents or bypass surgery?
And are you seeing a cardiologist currently?
Hmm.
These details all add to the bigger picture.
Okay. So once you've got that whole story, then comes the hands-on part, right? The physical exam.
That's right. And it goes beyond just listening to your heart with a stethoscope.
So what else is involved?
Well, first we'll check your vitals,
Right.
your blood pressure, your heart rate temperature, and oxygen levels.
Okay, standard stuff.
But then we'll do a really thorough exam of your heart and lungs, listening for anything unusual. You know, any murmurs, any wheezing, any crackles.
Oh, okay.
We'll also check your pulses in your arms and legs and look for any swelling.
Oh, wow. I didn't realize it was so extensive.
Yeah, it's important to be thorough. And believe it or not, we even do an abdominal exam.
Interesting.
It's all about considering all the possibilities.
So one of the things that really stood out to me in the material, potential causes of chest pain by how urgent they are.
Yeah, that's a great visual, isn't it? It really lays it all out there.
It does. And it shows you the whole spectrum from emergent all the way down to usually less emergent.
It's kind of amazing just how many things can cause chest pain.
It is. So let's start with that emergent category because those are the really scary ones, right?
Yeah, those are the ones you don't want to mess around with.
Yeah.
So at the top of the list, we've got things like myocardial infarction or MI.
Heart attack.
Yep. That's where a blood clot blocks blood flow to the heart muscle. And then there's unstable angina.
What's that?
Well, it's kind of like a warning sign that heart attack might be imminent. It's basically chest pain that's happening more often or more severely than usual.
Oh, so that's serious.
Yeah, very serious. And then you've got aortic dissection, which is a tear in the wall of the aorta.
And the aorta is,
That's the main artery that carries blood from your heart to the rest of your body.
oh, wow. So a tear in that would be really bad.
Yeah, it can be life-threatening. And then there's cardiac tamponade.
What's that one?
That's where fluid builds up around the heart and it prevents the heart from pumping effectively.
Oh, wow.
And then, of course, you have dangerous heart rhythm problems, like arrhythmias. Things like ventricular tachycardia or ventricular fibrillation. You've also got pulmonary embolism, which is a blood clot in the lungs,
Right.
and tension pneumothorax, which is a buildup of air in the chest that puts pressure on the lungs and heart.
Okay.
And then some issues with the esophagus, like esophageal rupture or a Mallory-Weiss tear.
Which is,
A tear in the lining of the esophagus, usually caused by violent vomiting.
oh, geez.
Of the heart muscle itself, which is myocarditis.
Okay.
You've got lung infections like pneumonia, fluid buildup around the lungs, which is called pleural effusion,
I see.
and then some other things like potential malignancies or a less severe type of pneumothorax.
And even in that less emergent group, there are still some pretty serious things on there.
Right.
Now, speaking of those life-threatening causes, I noticed they gave this really helpful mnemonic to help remember them.
Oh, yeah. PET map. That's a good one.
Yeah, it really helps to kind of organize those in your mind.
It does. So it stands for pulmonary embolism, esophageal rupture, tamponade, MI, or angina aortic dissection, and pneumothorax.
Okay, so if you could just remember PETMAP, then you can pretty much remember all the major life-threatening causes of chest pain.
Pretty much.
Yeah. What's next in figuring out what's causing the chest pain?
Well, that's where the investigations come in.
The tests.
Exactly. And the first and arguably most important one is the electrocardiogram, or ECG.
That's the one with all the wires, right?
Yep, that's the one. And it's essential for quickly assessing if there's a stemma, which is a specific type of heart attack where a major artery is completely blocked.
Okay.
It can also show other patterns that suggest the heart muscle isn't getting enough oxygen.
And it's also, so what other tests might be done?
Well, blood tests are often ordered to look at things like your complete blood count, your electrolytes, your kidney function, your blood sugar, and how well your blood is clotting.
Okay.
We also look at cardiac biomarkers like troponin.
What is troponin?
Troponin is a protein that's released into the bloodstream when there's damage to the heart muscle. So if your troponin levels are elevated, it's a sign that you've likely had a heart attack.
Okay.
And depending on the suspicion for a blood clot, a D-dimer test might be ordered.
What's that one?
It's a blood test that can help rule out a pulmonary embolism. It's not perfect, but it can be a useful tool.
And I see they also talk about imaging.
Right, imaging plays a big role as well.
So what kind of imaging might be done?
A chest x-ray is usually one of the first imaging tests done.
Okay.
It can show things like pneumonia, pneumothorax, an enlarged heart, and it can also sometimes give us clues about other conditions.
And then depending on what those tests show, maybe something more detailed, like a CT scan.
Exactly. A CT scan is a more detailed picture of your chest, and it can help us see things that we might not be able to see on a chest x-ray.
The thing that often comes to mind is angina, right? That classic chest pain.
Yep, that's a common one.
So they talk about these classic angina characteristics. What are those?
So classic angina has a few key features. First, it's usually located in the center of the chest behind the breastbone.
Okay.
Second, it's usually provoked by exertion, so things like physical activity or emotional stress.
Right.
And third, it's generally relieved by rest or by taking nitroglycerin, a medication that helps to open up the blood vessels to the heart.
Okay. So basically, if you have chest pain that comes on with exertion and goes away with rest or nitroglycerin, that's a pretty good sign that it might be angina.
It's definitely something to be investigated.
And it's a system that doctors use to figure out who needs the most urgent attention when someone comes in with chest pain.
There is. There's a tool called the heart score.
Heart score.
Yep. It's basically a way to assess a patient's risk of having a major cardiac event like a heart attack.
Okay. So how does that? Okay. So what are the different risk categories?
A score of 0 to 3 is considered low risk. 4 to 6 is intermediate risk, and 7 to 10 is high risk.
So a low-risk patient might be able to go home.
Potentially, yeah.
What are the next steps in terms of actually managing the patient?
Well, the first and foremost is to stabilize the patient.
Of course.
Make sure they're breathing okay, that their heart is beating regularly, and that their blood pressure is stable.
Okay.
So we call those the ABCs: airway, breathing, and circulation.
Right.
We also give oxygen if needed, put them on a cardiac monitor, and get an IV line in so we can give medications quickly if necessary.
Okay. And then once the patient is stable, then what?
Then the focus shifts to figuring out the underlying cause of the chest pain and treating that.
And sometimes that means bringing in specialists.
Yeah, exactly.